you, Ed. Next is Commissioner of DHS, Lucinda Jesson. She gets 2 extra minutes because Ed only spoke for 13. So, Commissioner Jesson, come on up. Everybody, I think before you came in, I mentioned to everybody that they have your bio, so I'm not going to elaborate on it. And your record will speak for itself. Thank you for being here.
It's great to be here with all of you this evening. I'm so much happier speaking about the Affordable Care Act decision when I've actually read it. I was thinking as I was driving over here about the last time I talked about this decision, and it was on June 29th. And that I'd been asked by the Minnesota Bar Association, so it was like their annual meeting, 500 lawyers, I know it's a scary thought, in one room, and they'd asked me to come and speak on the Affordable Care Act decision on June 29th. They asked me to do this, months ago, and I said, it could be, that's the last day of the Supreme Court's session, the decision, what if it came out just that day? And they're like, oh, no, it'll never happen. Well, yes, I'm there. I'm supposed to be speaking for an hour on the Affordable Care Act decision. I get it in my hands off the internet at 9:40 in the morning, and I'm speaking at 10:30. So I'd written this speech, kind of giving the background, the backdrop, and I had 3 different endings. But I didn't have an ending, actually, for what the court actually did, sadly. So I have now read the decision, and there are so many things that we could reflect on as far as what this means for Minnesota, and Commissioner Ellinger's mentioned many of them. And if you all have heard me speak, you know that those are things that are near and dear to my heart too, whether it's prevention and how we can use the tools in the Affordable Care Act to lower costs, to make sure we have better quality, but to have a better workforce that we're going to need. But I'm going to try and focus in my 15 minutes on Medicaid, which is certainly a large part of what we work on at the Department of Human Services. The Affordable Care Act decision, as I think you all know, left every state with 2 big decisions. One big decision is, are we going to have a state-based exchange, or are we going to go to the federal model? And Manny Manson-Margala is going to talk about that big decision. And the second big decision that states are going to have is whether or not to do the Medicaid expansion. And that's a decision that I certainly didn't anticipate that states would have, because if you remember, originally the Affordable Care Act said, the federal government will pay 100% of the costs for this expansion population. Let me just give you the backdrop so you know what that is. So under the Affordable Care Act, actually half of the people who are going to gain coverage through the Affordable Care Act, that half of them, 17 million of them, aren't going to do it through the exchange or because of a mandate. They're doing it because of the Medicaid expansion, where the federal government says for 3 years we will pay for 100% of the costs of covering those additional people up to 138% of the poverty level, about $15,000 a year. We'll pay 100% of those costs for the first 3 years, and then it'll decline to 90%. Because as most of you all probably know, Medicaid generally covers pockets of populations, children, parents of children, but typically does not cover single adults, even very poor single adults. So but what the Supreme Court said is basically, states, you get to choose whether or not you're going to take the federal government up on that offer. Now we're in a little different situation here in Minnesota because we are, as Commissioner Ellinger said, we've been ahead of this. Most states look at this, the Medicaid expansion, and whether they like it or not philosophically, would say, okay, we have the opportunity to cover a lot of single adults that we weren't covering before because the federal government wasn't paying for part of that. But of course, here in Minnesota, we have Minnesota Care. And we're already covering a lot of those people, not just up to 138% of the poverty level, but far beyond that. So we had a state program that was state funded that was doing that, and it makes it a little different for us in many ways. So let me talk about kind of just the logistics of the Medicaid expansion, and then kind of the additional populations that are covered by our Minnesota Care program today. Because if you think about it, other states are just saying, okay, do we take them off from this offer to cover people up to that $15,000 a year, that 138% of poverty level. Because remember, after that, under the federal construct, people can go into the exchange and get subsidies to purchase coverage. But we know in Minnesota care is offered to people up to, depending on up to $275, $250. So what do we do? How do we relook at our state programs with these federal opportunities, and they are good opportunities, in mind? Well, let's first think about that decision states had that we didn't anticipate having. Do we take the federal government up on their offer to cover basically single adults up to 138% of the poverty level? Remembering, these are people who are mostly on Minnesota Care today. And right now, we have actually, today, because it's something we negotiated with the federal government as a bridge to 2014, the federal government's picking up half of the cost of Minnesota Care for that population. Half of the cost. But that deal with the federal government to cover half the cost, because originally it was basically the state covering all of it, ends at the end of 2013. So do we basically say to the federal government, yes, we'll take you up on your offer to do 100% of the cost, or do we continue the Minnesota Care program where we are paying it with basically state dollars? I think another difference that we have to think about is the Minnesota Care program, as most of you all are very cognizant of. We have a hospital cap, that would not be there if we moved to Medicaid, which doesn't have hospital caps. And Medicaid has a richer benefit set overall than we have in Minnesota Care. So I think, but these are the things I certainly think about when I think about whether we should engage in the Medicaid, take the federal government up on their offer for a Medicaid expansion. From my perspective, it's a good deal for taxpayers, because we're already paying a lot of this with state dollars. It's a good deal for people, because they're getting a better benefit set. And it is very helpful to providers as well. And I think those are the reasons Governor Dayton, the very first thing I think he practically did when he took office was to sign the Medicaid expansion up to 75% of the poverty level. Those people up to up to making $8,000 a year. And people have asked me, they said, well, can we still do that? Or do we have to, is that still a good deal? Because right now for those people, the federal government's paying half. But if we take the government up on the Medicaid expansion, the federal government will pay 100% for those people for 3 years and 90% afterwards. But it is a state choice. And I mention this because I think this will be a big issue in the legislature next year. We don't know exactly what all the guidance will be from the federal government about this choice. Because let me tell you, even as a lawyer reading the Supreme Court decision, there are a lot of questions about the Medicaid expansion that remain unanswered. And we are looking for guidance and interpretation from the federal government. But I think the stark realities of that choice will still be there, basically, and I encourage you to become engaged. But let me also talk about the population now eligible for our Minnesota Care program above 138% of the poverty level. So above that, about $15,000 a year for an individual. Because as you all know, we have our Minnesota Care program, it has with sliding scale premiums, is available to many of those people. But now we have the option of saying, look, that population could go into the exchange where they would be entitled for subsidies that are paid for by the federal government. So I think we have basically 3 choices for that population and for those people. And those are choices that are going to be important choices for us to consider as a state. And right now when I talk about this group, I'm thinking of the people between 138% of the poverty level, that $15,000 a year, and 205% of the poverty level. And those are people that are, mostly the working poor, that are in many respects barely scraping by. And you all see those patients. You see them in your offices. You see them in your hospitals. So we have basically 3 choices, and these are choices that have been discussed in the Governor's Health Reform Task Force that's meeting. We'll make recommendations about this issue to the governor and to the legislature. So what do we do? Well, one choice is we just say we're ending Minnesota Care altogether, and we are just going to move those people into the exchange. We'll just take that population and say you can go to the exchange where they're going to have subsidies from the federal government to be able to buy products. Now let me kind of go through some of the pros and the cons of that first option. And I'm going to do this with the other two options too. Well, for a good thing about that, a pro, I think, would be that it treats all populations the same. There's less stigma. We know that some people who need help are hesitant to take what they see as a public program, a public handout, even when it's at those sliding scale premiums. So going in the exchange, could be less stigma. In the exchange, I assume the insurance companies will be paying commercial rates to providers. There'll be more choices probably for people in the exchange than they would be if they're choosing between 2 or 3 choices in our Medicaid program. And there's no premium cost to the state budget. For my world, it's not totally without consequence. But there's some real cons too. We know from studying this population that it is sicker than many others, which shouldn't be a surprise if you think about who they are. And so if you put them in the exchange, there's some implications for the exchange. It may raise premiums overall for other people who are using the exchange. I think there's real risk for uncompensated care. I think this is a big concern of mine. Because if this poor population goes into the exchange, they're going to be driven to what we'd say as a bronze plan. You get choices, kind of these 4 choices. Do you want the silver plan or the gold plan, or Manny will explain all of this, or the bronze plan. But for this population, the bronze plan will be the one that doesn't have a premium for them. They'll probably go to that, but what does it mean? Large deductibles. And these are people who can't pay them, can't afford them generally. So I think we're going to have a risk for uncompensated care. I think we could have a risk of parents being in a different health plan than their children, because a lot of those children are going to remain on Medicaid. And the benefits are different, will be, we believe, a little different and not quite as comprehensive as the benefits in Minnesota Care today. So we have, for example, a model mental health benefit set through Minnesota Care, and which probably will not have a few other things in the exchange. So there are pros and cons. So let me go through the second option. And that is put this population into the exchange, but basically have some wraparound services. So one of the things we're talking about, at least kind of at a minimum, is to say, look, let's at least not go backwards from where we are in Minnesota Care today. Let's not have more co-pays, more premiums in the exchange than you'd have in Minnesota Care. And maybe even do better if you could. And also, let's at least keep the same benefit set, at least that you have in Minnesota Care. So make sure that some of those mental health benefits are available. So that would be, so let me do the pros and cons again. Some of the pros of that would obviously be less cost sharing than just the exchange only. A little broader coverage, kind of depending on what, package you put together, or wraparounds. You could address some of the stigma because you're still having people in the exchange, and more choices. Would be less exposure for providers to uncompensated care than if you put them in the exchange without some of those wraparounds. And more choice for the beneficiaries. But the con, well, the supplemental cost, depending on how you structured it, but the supplemental cost would be a state cost. That would be ours. Of course, we are already paying through Minnesota Care some costs. It might be harder to administrate, we'd have to figure out administratively how to do it. And individuals who are struggling to make ends meet are still going to face some of the risk of underinsurance if they choose that bronze plan. But that's another choice. Now let me give you the third choice that's being talked about and debated. And that's a choice of a basic health plan. Now some of you all probably know what that is, but let me kind of just give you the real basics of it. The Affordable Care Act says to states, do we have a deal for you? The deal because it saves the federal government money, but they're saying, look, those subsidies we're going to pay during the exchange for this population, we will, instead of paying them through the exchange, we'll give them to you, or we'll actually, not quite, we'll give you 95% of the value of those subsidies. If you tell us you will cover this population and make sure they get at least the essential health benefit package. So basically, if we could say to the federal government, we'll take 95% of those dollars you're going to give to people as subsidies to buy their insurance, And we, the state of Minnesota, will basically create a public health plan to cover these single adults who are in the working poor, and that 138 to 205% of the poverty level. So here's some pros and cons to that one. Well, depending on how you structure it, it could be more affordable for consumers, right? We could make sure, once again, that we had lower copays and not those huge premiums or deductibles, so we could make it more affordable. We could get easier for families to stay together, so we don't have kids on a public plan and parents in the exchange. Easier transitions, we could, from Medicaid. One thing we're a little worried about is what they call the churn. Because this is a population where people will sometimes be working and then they won't, they'll lose a job and they'll get a job again, and going back and forth between the exchange and Medicaid. So we could, if it was kind of a seamless program, that we could address that. There's some benefits for beneficiaries that under something called the tax reconciliation risk, which I'd need a whole another 15 minutes to explain to you, so I won't. And now I'm not sure if there's a pro or a con. I suppose it depends where you are politically, but it's a more visible role for the state. Some cons. Well, certainly there's political pushback about an extension. Is this just government getting in the way? Let's let the private market do this. Provider rates. Let me just say, I think the way that the federal government came up with this approach and thought that states could do this for 95% of the value was say, well, look, you states, if you just continue paying your Medicaid rates, which I know are very popular in this room, you'll be able to save money and then be able to provide lower copays and more benefits to this population if you do a basic health plan. So that certainly is something we would have to think about as well. These are just three options for what to do with kind of a working poor population that's under Minnesota care today. We also have the Medicaid expansion, and all of this is whether you other people look at this and say, well, this is talking about what's the future of Minnesota care. And I look at it more and say, what's the future for these people who are struggling, who need our help in one way or another? And what's the best way to make sure that as a state we're not going backwards from where we've been? And hopefully to continue to move forward for our population, and and really continue to have the great healthcare infrastructure we have. So what we've done at the governor's task force level is say, okay, if we say at a minimum we don't want to move backwards, we want to make sure we have at least the benefits we have under Minnesota care, except no more $10,000 hospital cap. And we want about the same level of out-of-pockets for these individuals. We don't want those to dramatically increase. What would it cost to do that? And so we are looking at those numbers. We're looking at both scenarios. What would it cost if we did it, kind of putting people in the exchange with wraparounds? What would it cost if we did it through a basic health plan? So that at least when policymakers are making that decision, is it an exchange? Is it being in the exchange, but with something more the state helps with? Or is it a basic health plan? We'll know what the implications are for people, for the state budget, and for providers. So I know this is a little esoteric, but I certainly wanted to make you aware of this because I think those are important discussions we need to have as a state this year.